These are some of the things that the pharma industry, are known to do, and it's been written about, and they haven't sued. So clearly, they know this is the case. They ghostwrite articles. They pay eminent researchers to put their names to articles which are written by the industry. They target the public with their advertising, and pharmacists and doctors. They target the public in the USA. They can't do it here. But what they do is they suppress negative results, and people who drop out. If someone drops out of a clinical trial, they're not included in the numbers. So it's only people who've got through or people who die when they're taking medication. They don't record that very often. So there's lots of ways in which they skew their results quite dramatically, and I've seen some of it. When I was asked to look at some. Anyway, I won't go into that, it's too complicated, but they do some quite dubious things to prove that their medications work, that they're effective. And that there's loads of money behind it, so it carries on. This is the Project SURE, which is a research enterprise at the Institute of Psychiatry, which Alison mentioned. They did a systematic review of ECT, and they looked at patients' accounts of ECT, first-hand experiences. They found that very few studies ever follow people up longer than 6 months, even as long as 6 months, so it's only very short-term in the usual research. They found that memory loss is a persistent side effect that profoundly affects people's lives, and that ECT doesn't have any long-lasting benefit. So that was different to what you get in the RCTs, because they only look short-term, they don't follow up people long-term. And they claim that it has an impact, but it does have an impact. Of course it does, because it makes you feel, very confused, and you probably forget what the problem was you came in with, but temporarily. But it's not necessarily have a good effect. I mean, we could argue about that all day probably, because I know some people who've had ECT did find it beneficial. But doctors who give ECT have not been very interested in patients' views. And this study was also done. I think this was also done this is also done by SURE in the institute. They looked at people's experiences before and after ECT, and 45%. They looked at it over quite a long period. 45% reported persistent memory loss. 47% felt they'd been pressured to have it, even though they weren't actually under a section. It was the first time that this kind of study had been done with a service user designed questionnaire, so that was quite an important thing that they did. And because our National Institute for Clinical Excellence had asked for this research to be done, had asked the Institute and SURE to do this, they then had to act on it. And they put some quite sort of strong warnings in their guidance. The National Institute for Clinical Excellence, they produce guidance on treatment, which has to be taken seriously by doctors in the UK. They said that they considered that there's lots of uncertainties about ECT and the longer-term outcomes. That individuals report negative experiences, and that it should be used with caution and only under the restricted circumstances recommended in their guidance. And they said that there wasn't evidence for it to be used in schizophrenia and things like that. So that bit of service user-led research had an impact on our national policy on ECT. There was also apparently quite a quick negative response from psychiatrists, some of the psychiatrists who didn't like this new restrictions being put on ECT and thought that was out of order. But they didn't win, so it's still the guidance now. It's nothing like what we'd want. We might want it, but for me, I'd like it either to be banned or to be put under, not able to be given against anybody's will, or under any kind of coercion, and with much better information, which actually states that it causes memory loss, which it does. Because there is anyway. But we got somewhere, we made some impact, so that's good. After 20 odd years of campaigning, we made a small little dent. Linda Andre covers this in her book on ECT, and how the psychiatrists all started screaming and shouting about it afterwards, but didn't manage to get NICE to change their mind. Phew. The personality disorder, I think that, you know, Alison was talking about that research, I think it does seem to have had some kind of an impact. Yeah, there's a couple of bits of research that were done, that the service user led in Colchester and St George's Trust, where service users were researching personality disorder and what people need, using narrative analysis and reflective diaries and stuff. And this helped to influence the Department of Health's work on personality disorder, and setting up pilot personality disorder services, which Alison was involved in evaluating. I think one of those was a crisis house for people with personality disorder in Colchester. And based on all the work that has happened on personality disorder, the most recent NICE guidance on borderline personality disorder came out in January 2009, and they've reflected quite a lot of service user experiences in that guidance, which would not have happened before service users did all this work on PD. It looked at the importance. They set out the importance of autonomy and choice, trusting relationships, the role of abuse and trauma, and encountered stigma, and the role of psychological treatments and drug treatments, and they're not very positive about the role of drug treatment in borderline PD. So again, we've had an impact on national guidance, or service users with personality disorders have had an impact on what NICE have come out with this government guidance. I'll just finish with the dangers of co-option of our concepts. Recovery, what service users believe recovery to be is about self-identification of causes and problems and causes, what we need, regaining power over our lives, finding new activities that we enjoy, and reducing our dependence on services as far as possible. Service providers, they insist on classifying us into long-term severe patients and people with sort of worried well, people who just go to primary care. They focus medical attention on people with long-term needs. And then when they get the idea of recovery, they want to reclassify a lot of the long-term patients as going back to primary care, not needing the intensive services that they used to need. They measure recovery by whether you get a job. So this is not at all, it's not a close match between our idea of recovery and their idea of recovery. Unfortunately, they're the ones who pay, and we're in danger of going down this second road with recovery, which is really turning service users off completely. You know, they don't want to be forced into a job, they don't want to have their benefits taken away, they don't want to have their services taken away. So it's a problem. And the same with self-management. We've got lots of really good work on self-management, peer support. We've also got something coming from America, which is called illness management, which is doctors teaching you about your illness, teaching you how to use your medication properly, take it regularly, and basically, do what they tell you. And learning how to manage and reduce relapse, and coping skills to manage stress and reduce symptom severity. So again, there's not a close match between their idea of illness management and our idea of self-management, but we have to watch out that we actually get self-management to be the one that gets funding and which gets proper research done on it, and not just the illness one. Towards coming to the end. The way that we can influence service delivery is we can bring in concepts of recovery and wellness, so that services actually start to look at those as what they're trying to achieve. And lots of services, you probably I don't know how much you have that in Ireland. We certainly have a lot of services now which, at least in theory, are looking at recovery and well-being. Our national charity Mind are now developing well-being centres all over the country. A lot of their local services are supposed to now be well-being services. Whether that is what, I don't know, we have to wait to see. I think they've put in some evaluation to find out if that's working or not. There are tools that can be used to measure outcomes that we want, such as the Recovery Enhancing Environment Measure, Recovery Assessment Schedule, HOPE Index. There's an empowerment scale developed by the Boston University people. There's things called goal attainment scaling, which measure individual goals that people want to set for themselves. So ultimately, we need changes in legislation to give us more rights to quality services and eliminate discriminatory practices, but we're sort of on the way. What we don't need is tokenism and corruption and hijacking. What we do need is better outcome measures. All the mental health research to involve us, more use of narrative methods, more implementation of service user-led or service user involved research, and more training to do it ourselves. Where we are involved in research, it has led to changes in policy and treatment, and better understanding of problems with medication and self-management. And this is influencing voluntary organisations and policymakers. So with greater awareness of what we can contribute, we could greatly reduce pessimism around mental health and mental illness, reduce stigma, and begin to change the paradigm.